Now we'll discuss intracranial pressure and head injury. Let's start by reviewing basic principles of intracranial pressure. The Monroe-Kelly doctrine describes how the skull is a fixed volume box containing brain, blood, and CSF. Any increase in one part must result in a decrease in the others to keep volume fixed. Intracranial blood can decrease volume through reducing the high-capacity venous system. CSF may shift outside to the spinal canal or chronically through increased drainage. Brain tissue can reduce in volume by intracellular and interstitial fluid shifts. As demonstrated in the graph, initial mass increases can be compensated for, but beyond a certain point, compensation is overrun and ICP will increase. A feared complication of increased ICP is brain herniation, where a portion of the brain tissue in a high-pressure region shifts to a low-pressure region, such as past the cerebellar tentorium. Causes of increased intracranial pressure include mass lesions such as tumors, hemorrhage, edema, or pus. Altered CSF production or drainage causing hydrocephalus can also increase ICP. Trauma can increase ICP through either hemorrhage or edema. If critically elevated, intracranial pressure should be lowered to prevent herniation. Initial treatment options include elevating the head of the bed, which increases cranial venous return, and hyperventilation. Hyperventilation can be induced through altering mechanical ventilation settings. Hyperventilation lowers PaCO2, causing cerebral vasoconstriction and a decrease in cerebral blood volume. However, hyperventilation is only a temporizing measure, as rapid re-equilibrization occurs. If abruptly stopped, rebound increases in intracranial pressure may occur. Hyperosmolar therapies with mannitol and hypertonic saline reduce intracellular volume in the brain. Surgical treatment options include placement of an external ventricular drain to remove CSF, hemicranectomy to remove part of the skull and allow the brain to swell, and mass lesion removal. Now let's switch to discussing traumatic brain injury. Violence is the most common underlying cause in younger patients, and falls are the most common cause in older patients. Traumatic brain injury results in both primary and secondary damage. Primary damage is from the external force on the brain. In closed head injury, this results in contusion, bleeding, or shearing injuries. In open head injury, there is often bleeding. Penetrating trauma may cause bleeding, direct tissue interruption, and concussive forces from projectiles. Secondary damage results from the body's response to primary damage. Some of these mechanisms are part of the healing process, and this damage happens hours to days later. Secondary damage occurs through a variety of mechanisms, including from excitotoxins like glutamate, free radicals, apoptosis, mitochondrial dysfunction, inflammation, and ischemia. One of the tools we use in the assessment of traumatic brain injury is the Glasgow Coma Scale. The Glasgow Coma Scale has 3 components that sum to a total score of 15, including the eye, motor, and verbal components. Clinically, it's most useful to list both the total and component scores. While a normal GCS score is 15, that doesn't necessarily mean that a patient is completely neurologically intact. In general, though, mild TBI will have a GCS score of 14 to 13, moderate TBI will have a GCS ranging from 12 to 9, and severe TBI will have a GCS score of 8 or less. Thankfully, the majority of cases of TBI are mild. Let's look at common types of traumatic head injury, starting with bleeding injuries. Bleeding injuries include epidural, subdural, and traumatic subarachnoid hemorrhage. In epidural hematoma, trauma disrupts a cranial vessel like the middle meningeal artery, and blood accumulates between the dura and periosteum. On imaging, a lens-shaped blood collection restricted by suture lines may be seen. Classically, epidural hematoma presents with an initial loss of consciousness, followed by a lucid period, and then followed by subsequent deterioration. In subdural hematoma, bridging veins are injured, leading to bleeding between the dura and arachnoid. This lower pressure bleed is seen as a crescentic blood collection that may cross sutures. Because venous blood accumulates slowly, these injuries may present subacute to chronically. Recall that newer blood is bright on CT, while older blood is isodense to hypodense. Subdural hematoma often results from very strong forces and is associated with brain tissue damage, resulting in higher overall mortality than epidural hematoma. Traumatic subarachnoid hemorrhage occurs when head injury causes bleeding between the arachnoid and pia mater. It is best seen on CT as hyperdense material filling the sulci or cisterns. Injury can also occur directly to the brain parenchyma itself during trauma. This produces a cerebral contusion, essentially a brain bruise, often caused by rapid acceleration-deceleration, leading to back and forth shaking within the skull, known as a coup-contre-coup injury. The frontal, temporal, and occipital poles are most commonly injured. It is seen on imaging as spotty hemorrhage and edema that often blossoms over time. Finally, penetrating injuries include depressed skull fractures, gunshot wounds, or stab injuries, which can disrupt vital connections in the brain. Traumatic brain injury is mostly seen in adults and adolescents, but infants are incredibly susceptible to head trauma. Infant head trauma often results from non-accidental trauma from abuse. Injury can be caused through direct blows, compressive injury, acceleration-deceleration injury, rotational forces, or asphyxia. Many different injury patterns may suggest non-accidental trauma, but retinal hemorrhages or multiple subdural hemorrhages of different ages, called mixed-density subdurals, particularly suggest non-accidental trauma. When discovered, non-accidental trauma requires immediate reporting to Child Protective Services. Finally, let's discuss concussion. Concussion is a form of mild TBI, but not all mild TBI is concussion. Concussion is a traumatically induced transient brain dysfunction. The pathophysiology of concussion is poorly understood, but it's likely multifactorial. Common signs and symptoms include headache, nausea and vomiting, disequilibrium and dizziness, fatigue, cognitive changes, changes in mood, and difficulty sleeping. After initial assessment and ruling out of other neurologic injury, patients should be serially assessed for continued symptoms. Initially, patients should rest, and as they recover, undergo a gradual return to their normal activities. This helps to avoid second impact syndrome, when patients with recent and completely healed concussions are more susceptible to brain injury. Repeated injury can lead to permanent serious neurologic disability, including chronic traumatic encephalopathy, a poorly understood neurodegenerative process that is thought to be due to repetitive traumatic brain injury.